started in the 1920s, and it's become a new paradigm in modern medicine that really changes outcomes, and that's changes lives. Seriously? Hang on. All right. So all of you are in clinical practice or research practice, and you have to ask what would happen to your practice or your personal health or your patient's health if you could reduce inflammation, normalize immune activation, reduce stress hormones, reduce or eliminate central sensitization, spinal cord sensitization, activate the vagus nerve, balance autonomic function, and increase ATP by 500% quickly, without drugs or side effects. And there was a reasonable mechanism of action and some data. So frequency-specific microcurrent we're going to talk about for the next 40 minutes or so. It's a new tool you probably didn't know you needed that does something you didn't think was possible. The history is, to me, fascinating because I was a Western medicine trained pharmaceutical rep, went to chiropractic college because I was 42 and had 2 little kids and didn't make the cut to get into medical school, thank goodness, and there were no osteopathic colleges in Portland. So frequency-specific therapies were developed in the early 1900s in the US, England, and Europe by MDs and mostly osteopaths, and they were used by thousands of physicians until 1934. Abrams was just one of them. There were probably 5,000 to 7,000 in the US. So, where am I? There we go. So medicine labeled all of the alternative therapies, homeopathy, herbs, nutrition, everything we do now, as ineffective fakes starting in about 1910 with the Flexner Report, and 1917, they got more serious about it. In 1925, they declared that drugs and surgery were the only tools of medicine, and nutrition, herbs, homeopathy, and frequency therapies were outlawed. Every medical intervention except for prescription medication was made illegal. And physicians who used these tools would lose their license. Practitioners, some of them went to jail. The devices went into the back room, got covered up with a sheet, and the research and the history were lost. Those of you that have buried a parent or a grandparent, there's grandfather's library. What do you do with all of that research? It's all gone, except for some that we found in the rare book room at the Naturopathic College in Portland. But Harry Van Gelder was an osteopath from England who bought a practice in 1946 that came with a machine and a list of frequencies that was built in 1922. So 1935 was when everything really went underground. So it was only 11 years later. Harry bought this practice, walked into the back room, pulled the sheet off of the machine, and found this list of frequencies under the machine. So there's a number, which we assumed was a frequency, 9 hertz, and that was for allergy reaction or histamine. George Douglas was a chiropractor who worked with Van Gelder in 1983, and he brought home a copy of the list and stuck it in a drawer. When I graduated from chiropractic college in 94, he moved and found this list in a drawer in 1995. And we started using it with a 2-channel analog precision microcurrent that was a offshoot of Wing's myomatic eye. So the thing I had to live with was that I have no idea how the frequencies were derived. Uncertain of the mechanism of action. The 1920s equipment was not microamperage current. It was DC current back when wall current was direct. and the 1920s therapy was not FSM. So I first used them in 1995 to treat muscle and nerve pain. The frequencies were first taught in 1997 because I had to find out if they were reproducible. It's like, okay, fine. I can melt trigger points. I can get rid of muscle pain and get rid of nerve pain, but is it real? It's only real if it's reproducible. So I taught the class badly in January 17th of 1997. And about 10 to 15 practitioners, mostly chiropractors and naturopaths, bought machines from the local distributor and started using them. And by June, we knew that the results we were getting in the clinic with muscle pain were consistent. And the benefits are consistent, and more important, the effects are teachable and reproducible. If I was the only guy that could do this, it wouldn't matter. Research in animals and humans and clinical results have accumulated over the next 20 years, and we'll go over some of those papers. So all of you know that drugs and nutrients change cell function more or less like keys in a lock. So if you have a pathogen-associated molecular pattern or a damage-associated molecular pattern that land on a cell receptor, changes kinases, transcription factors, genetic expression, messenger RNA, microRNA, and that creates pro-inflammatory cytokines. Well, if you stick ibuprofen in that receptor, it blocks the ability of that cell to produce prostaglandins. And so it is an anti-inflammatory that acts like a key in a lock. Frequencies seem to change cell function with a signal, kind of like your key remote. They have, and I say appear to, because this is a testable model. We haven't been able to find a genetic research company that will prove that the model is correct. The frequencies appear to change membrane receptor function and cell function electromagnetically. So your key remote, your key fob, sends a signal exactly and only to your car. Your key fob opens only your car, even if there are 12 identical cars in a row. Your remote only opens your car with a single frequency that is tuned exactly to your car. FSM seems to work like that with specific problems in specific types of cells. So we did animals research at the University of Sydney in Australia with Vivian Reeves. She's a PhD veterinary science researcher, and her whole field of study for 20 years had been anti-inflammatory drugs. So you paint arachidonic acid on a mouse's ear, then you measure it with calipers, this little guy, and then you give the drug mouse, the mouse a drug afterwards, drug a mouse, give the mouse a drug afterwards, or you do something before to try and reduce the amount of inflammation. So there's a frequency 40 hertz to reduce inflammation, and 116 hertz was the frequency on the list for the immune system. And the first 10 mice they did, there was a 70% reduction in lipoxygenase mediated inflammation, which is created by painting arachidonic acid on the mouse's ears. And Vivian shut down the lab. She sent everybody home because in 20 years of doing this research, she hadn't found any prescription or non-prescription drug that reduced inflammation by more than 5%.
Shut up.
So everybody came back.
Quiet.
Somebody want to mute? Thank you. So everybody came back the next day. Everybody was in a separate room with shades drawn or paper on the windows. And with everybody blinded, there was a 62% reduction in lipoxygenase mediated inflammation. Then they paint myristoyl steroid on the mouse's ears. And there was a 30% reduction in COX-mediated inflammation, which doesn't sound that good, but that's equivalent to injectable Toradol when it was tested in the same animal model by the same researcher. And that's when we found out, this was done in 2000, 2001. That's when we found out that it's a 4-minute time-dependent response, which ends up being important. It suggests that the cell signaling model is probably correct. So when she did this, she also turned the machine away from the guy who was treating the mice. This is Wayne Riley. He's a naturopath or osteopath in Australia. And there he is holding the mouse by the nape of the neck and by the tail. And she turned the machine away from him and put in a placebo frequency. And it's a blinded placebo trial for reasons I'm still not clear about. She wouldn't publish it. She wasn't close enough to retirement. So I had them try other frequencies and there was no reduction. So the current alone with just 1/10 of a hertz, no reduction in inflammation. We used other frequencies that were from our list. 91 hertz is for mineral deposits, no reduction. 4 minutes of the frequencies for trauma and rebooting, so to speak, and allergy reaction gave no reduction in swelling. And then in 2000, I treated the first group of 25 in a year, fibromyalgia associated with spine trauma. The fact that about 27, the published literature says 27% of fibromyalgia patients get it associated with spine trauma. My clinical research says it's closer to 40. And I stumbled across a frequency combination. This is the pain diagram, and it is characteristic of this kind of fibromyalgia. Stumbled across a frequency combination, 40 hertz on channel A and 10 hertz on channel B for the spinal cord, because they have full body pain and nothing made sense. This is not regional, it's system-wide, and it had to be associated with spinal cord. I thought. I tried it once, and at the end of 25 patients, we knew pretty clearly that it was 100% effective. Only one frequency reduced pain, only one frequency reduced inflammation, and they came in with their pain as an average of a 7.4 out of 10 and left at a 1.3 out of 10. And I presented this at the National Institutes of Health. One of my students is a physiatrist at NIH. His research is in the area of myofascial pain. And he invited me to do a grand rounds. And I had these 25 patients, and I said to the 30, 35 assembled clinicians, I've done this 25 times. It's completely predictable, reproducible, and nobody's going to believe it unless I have data. Well, Terry Phillips came up and said, you tell me you give me a spot of blood on blotter paper, and I will tell you what's changing. And what we found, thanks to Terry Phillips, was that all of the inflammatory cytokines were reduced in 90 minutes. Getting them to recover getting them out of pain was easy. But the recovery program was individualized. So they had FSM to keep their pain down, physical therapy because all of them had disc bulges, usually in the cervical spine. They had to be reconditioned, go for a walk, spinal stabilization, had to repair the gut, the adrenals. Then the thing that takes the longest is medication management and withdrawal. And it's pretty simple setup. Towel around the neck. We use wet towels to conduct the current because it's easy, inexpensive, and we do cover them up with the blankets so they stay warm. But this is what we found out from Terry Phillips. Interleukin-1 in the index patient, I don't have that slide, but in all, we published 54 cases. Interleukin-1 was reduced from an average of 330 down to 80. That p-value has 2 zeros and a 4. TNF-alpha went down 305 down to 78. Interleukin-6, 239 down to 76. Substance P, 180 to 54. And the interesting thing about substance P is that it is manufactured in the spinal cord and transported peripherally. There are some substance P neurons peripherally, but the primary generator for substance P is in the spinal cord. So David Perlmutter, when he saw this data at IFM, I presented it at Institute for Functional Medicine Symposium in 2000. He said, well, if you change substance P, it means that 10 hertz is actually affecting the spinal cord, and that p-value has 3 zeros. Beta endorphins go up. These patients get so stoned they can't talk. Went from 8.2 to, that's a 10-fold increase, just about. P-value has 2 zeros and a 3. And the pain went down from an average of a 7.4 to a 1.4 in 54 patients. That p-value is 3 zeros and a 1. And the statistics actually are 6 zeros and a 1. But the statistician is British, and he said that anything more than 3 zeros is just showing off. So in medicine, inflammatory cytokines are hard to change, and when they change slowly, they change slowly over months. So it was only 40 hertz on A and 10 hertz on B that reduced all of the inflammatory cytokines and the pain. It's very specific. Nothing else works. And it reduced them all by 10 to 20 times in 90 minutes. And when they returned, the few cases that I had, they returned at a much reduced level. Okay, all of you ought to be asking, how can a frequency or a pair of frequencies do that? Well, here's the idea. The NIH data shows that interleukin-1, interleukin-6, TNF-alpha, interferon gamma, CGRP, which I didn't publish, substance P, and endorphins all change. Well, they're all made inside a cell in the spinal cord. The only thing that makes sense as a model is that only changes in cell signaling could normalize all of them so quickly. So cell receptors, I'm sure you all know, respond to external factors like bleeding, bacteria, tissue fragments that activate kinases, that change transcription factors, that change genetic expression to create inflammation. Inflammation doesn't come from space. It comes from every single cell in your body that has a receptor that can sense all of these promoters. And the data suggests that cell receptors respond to frequencies signals to turn that inflammation off, even in the presence of infection. So if a patient has an occult infection that you think is just due to inflammation, the frequencies will override the signal from the bacteria and turn the inflammation off, even in the presence of infection. So microcurrent devices were approved in the 70s as if they were TENS devices, because that was the cheapest way to do it. They're not TENS. It's 1,000 times less current. It's physiologic. There's an over-the-counter use for aesthetics. It's used for wound healing. There's over 200 papers on microamperage current and wound healing. It's used for pain control, but they vary widely. They have different waveforms. They have one channel. They have two channels. There's combined units, ultrasound, interferential. The frequency up until 1997 wasn't important. There was a limited number of frequencies, 0.3 hertz, 30 hertz, 100 hertz, or there was a sweep of frequencies in a device called an Acute. So the Fsm units have to have two independent channels where you can set a frequency on channel A for a condition, frequency on channel B for a tissue, and it has to have a screen that shows what's running. And the frequencies have to be 3 digits, because there's a frequency for a tendon that's 191 hertz and a frequency for bursa that's 195. And the question that nobody knows the answer to is how somebody in 1922 decided that the frequency for a bursa was 195. We have no way to know. All of that is grandfather's trash heap. There were animal studies done in 1982 by Nak Cheng, and he showed that as long as the current was under 500 microamps, it increased ATP production by 500%. increased protein synthesis by 70%. That increased amino acid transport by 40%. And then Seegers followed up on his work in 2001 and 2002. And she demonstrated that it increased cyclic AMP in human lymphocytes. And she had data that showed that it activates signal transduction, which means that it helps the cell communicate with other cells better. So frequency-specific microcurrents, not about the device. Back in 1997, we had the only game in town. Now there's a lot of Chinese knockoffs. Our devices are made in the US, but FSM isn't about the device. It's about the frequency effect. So Fsm improves healing. This is a diabetic patient, obviously necrotic second toe, and he had a 7-centimeter wound on the medial side. He had a lot of edema, sensation loss in 7 out of 10 areas, and it was all healed in 6 weeks in 6 to 11 treatments. If you've treated diabetic patients, you know that they were just waiting for this to get worse and that to get worse so they could do the amputations all in one day. At the end of 1 month, his pain was eliminated. His sensation was completely normal. This is unattended. Contacts at the knees, contacts at the feet. And as you know, diabetic neuropathies is all about ischemia. So the frequencies we used for the first year didn't work because I was treating the nerves. What we found was if you treat the blood vessels, it gets better. And we haven't found anybody that it doesn't work on, and I can't get anybody to fund a study about it. In skin anti-aging, this lady is pretty to begin with. Her husband is a plastics and maxillofacial reconstructive surgeon. And so he's the one that did this presentation, I think, in about 2012. And pre-treatment, you can see here, post-treatment, jowliness is gone, the orbital lines are gone. The best thing is the labial folds flatten out. There was a study done at University of Washington in rabbits where there was a 39% increase in blood supply after 20 days of treatment. So it's what you do when you have a graduate student that needs a paper, a dissertation. So they just ran 0.3 hertz on a rabbit. So they biopsied the bunny, treated it 5 days a week for 4 weeks, and with just 0.3 hertz, just the current, not the frequencies. And there was a 39% increase in blood supply, 14% increase in collagen, but for osteopaths, those of you that do physical medicine, there's a 48% increase in elastin. And that's what does this, right? Elastin is what keeps scar tissue from being so restrictive and damaging. So that's just the current. We had one practitioner in Australia who had a patient come in with acute alcohol intoxication on a Monday morning, fatigue, nausea, digestive problems. He went on a bender over the weekend, but clearly he was a chronic alcoholic. His initial blood levels, his AST was 75. They didn't do anything except tell him to stop drinking and gave him some nutritional supplements. And as you know, when AST is elevated, it's elevated because the liver cells are breaking apart and the enzymes are flowing out in the blood supply. In acute alcohol poisoning, you expect AST, all of the liver enzymes, to go up for 10 to 14 days and then come down over about a 2 to 2.5 week period. So it wasn't surprising that 2 days later on Wednesday, his AST had gone from 75 to 582, ALT 222 to 547, GGT went from 383 to 709. And on Wednesday morning, what was his name? Joe Sudich is a nurse and naturopath. He did a 60-minute treatment with FSM for the frequency, with the frequency to reduce inflammation in the liver in the morning. So had him tested at 9 o'clock, treated him from 10 to 11, and at noon, had him go back to the hospital to get tested. And his AST went from 582 to 36 in 4 hours. That's not possible. And I'd say it was a lab error, except that it's now been replicated in 3 different clinics in the US in the last 5 years. Postoperatively, we don't have anything published in post-op, but this is day 1 after a mid-face brow and lower facelift. I don't think she had her eyes done, but it's good surgical technique, drains, compression, ice, all of that. And one of our practitioners did an 80-minute treatment immediately post-op, and we'll talk about maybe a 4-hour window, and then treated her daily for 7 days. So this is day 2. This is day 4. You can see there's a little bit of bruising in the mid-face, some swelling. Day 5, there was swelling here, but still no bruising. Day 6, a little bit of bruising right there. Day 9, cheeks are swollen again, but I think that's because her hair is back. I think that's optical. But this is day 11. And those of you that have seen patients after full facelifts, nobody looks that good 11 days after a full facelift. So that's the only one we have. We're looking for practitioners to publish things post-operatively, because you can do a hip replacement on somebody. I've had both my hips replaced. I used FSM immediately after the surgery, and I didn't bruise. There's a frequency that dissolves abnormal scar tissue. I did a study in 2003 at Mercy St. John's in Springfield, Missouri. Every patient had statistically significant permanent increases in range of motion after 3 one-hour treatments. So they measured, PTs measured the patients on Monday and Friday, and I treated him Tuesday, Wednesday, Thursday. This is a patient in Taiwan. It was 3 years chronic, full thickness burn. He was burned in a fireworks accident. His clothing caught on fire, and he had 80% of his body burned. His elbow was stuck in 15 degrees flexion before treatment. After 1 hour, his elbow was straightened, and someplace on the internet, there's video of him having his foot stuck in 90 degrees of dorsiflexion. And at the end of 60 minutes, he's able to completely plantar flex and dorsiflex it. We have a paper published where we dissolve scar tissue after an ulnar nerve transposition in a patient that had had 11 physical therapy treatments. Let's see, what is this? 9 years after the original surgery. His pain, incoming pain was a 5, his outgoing pain was a 4. His TAUS went from 86 to 92, but a year later, his pain was a 7. His TAUS was down to 80, so it was worse than it was when he started. And basically, you run the current from where the nerve starts to where the nerve ends. And pain level was 0 at discharge. His TAUS was 100%. And we waited a year to publish the paper, and the results were identical at the end of 1 year. So it was maintained. Dissolving scar tissue is one of the easiest things we do. So you got to be asking, how would a frequency change conditions in specific tissues? Well, the effect of the frequencies is immediate. It happens in 10 to 20 seconds. The tissue gets soft. We call it smush. Patients and practitioners can both feel warmth or changes in pain, and these all stop when the frequency is finished. And then there are lasting effects if there's a good environment for them. So we're all based in science. Science starts with observation. So how does science explain what it is that you see when you do frequency-specific microcurrent? The fact of the matter is that the human body is a quantum biological system. That we throw that word quantum around pretty loosely, but it actually makes sense in this setting. Living tissues, biochemicals, okay. what does that mean? Well, they're molecules, atoms, and subatomic particles that are held together by electromagnetic bonds. Citric acid cycle is molecules organized. So Newtonian physics describes large objects really well, but it falls apart at the molecular level. So your body is a large object made of molecular substances, molecules, atoms, and subatomic particles that all held together by electromagnetic bonds. And every bond has a frequency at which it resonates. So this is insulin. We think of it as a liquid that's produced by the pancreas, but it's not. It's molecules held together by electromagnetic bonds. So there's another piece of this, and that is that water lines the gel inside the cells and forms structures that act as a semiconductor. So back when I took biology, we thought that the cell was full of liquid. And the fact is you can cut a cell and nothing drains out. It's like jelly. It's lined with a matrix that is lined with water. And the water molecules flicker. And there's a hole in the outer shell that, because the water molecules are held in place, that hole is in exactly the same place all the time because of the way it flickers. That makes it very much like a silicon crystal, okay? Silicon is a semiconductor because there's a hole in exactly the same place in this silicon matrix. So your body's an electromagnetic system that looks solid, but the cells function as a semiconductor network. We don't think of it that way because you don't have to think about it that way. I had to figure it out because I'm using current, charge, and frequencies as information. And it turns out that it works because the body's a semiconductor. So what's resonance? Resonance is the tendency of a system or a bond to oscillate at large amplitudes in response to some frequencies, but not others. At the resonant frequencies, very small forces can produce very large amplitude vibrations. So they found out in the 17 or 1800s that soldiers marching in step across a bridge, back then it was a wooden bridge, or maybe even a metal bridge, could collapse the bridge because their footfalls created a resonant frequency that matched the frequency that held the bridge together. Resonance effects explains the immediate effects. Why does this stuff work so fast? Well, when a singer sings a note that breaks a lead crystal glass, that works not by volume, but because there's a precise frequency holding lead atoms together as long as the matrix, the crystal matrix, is 70% lead. The lead atom bonds vibrate with the singer's note. If it is precise and sustained, the lead atoms vibrate and the crystal just comes apart because the lead atoms vibrate instead of being bonded to each other. Thankfully for me, the number one basic principle of science is observe, verify, repeat, predict. If it happens again, you observe that. The number two basic principle of science is you can't throw out the data because it doesn't match your model. I didn't have a model in 1995 when I started using this that said that frequencies were going to do this. Even I didn't believe what it was I was saying. And the third basic principle of science is you can change the model and start over. So FSM changes tissue quickly, but it needs manual and exercise therapy, nutritional and lifestyle changes for lasting permanent results. So everybody in this group had to take physics, right? Well, you remember from thermodynamics, the concept of energy wells and stable states? That's what explains the lasting effects. So water same substance. As long as the surrounding milieu is 0 degrees, it's solid. You add energy to the system, you change the surrounding milieu to something between 1 and 99 degrees centigrade, and water is completely stable as a liquid. Add more energy to the system. As long as the surrounding environment is 100 degrees centigrade, water is completely stable as steam. So the correct frequencies create instantaneous changes that change the state of the tissue, and those changes can be permanent as long as the patient's metabolism, attitude, body mechanics support the change in state. So it takes nutrition, sometimes it takes emotional support. Most of the time for physical medicine especially, it takes exercise therapy and reconditioning. So FSM treatment, we've been using it actually since 1995, but it's been taught since 1997. It's low risk, it's reproducible. Thank goodness for me, it's teachable. And so if I teach somebody how to do it and it suits their mind and their skill set, it's reproducible, it's reliable, it's non-invasive, it's comfortable, you can't feel the current. 500 or 300 microamps, 100 microamps is subsensory. You can't even feel it. It is billable because the devices are approved as TENS devices. And the equipment is reliable, inexpensive as equipment goes. So, published papers. I was married to David Simons. Some of you may have heard of Travell and Simons, the trigger point manual. David Simons fell in love with me in 2005 because I made treating trigger points easy. And we were married in 2006, and he passed away in 2010. So he had shingles in the ophthalmic branch of 5, and when he was 85, I treated him with the frequency we had for shingles at the time. It was only one frequency pair. I ran it for an hour around his neck and across the top of his head. He was pain-free in 1 hour. Pain did not return. I treated him again that night in our room for 2 hours, and the lesions were gone in 48 hours. These days, there are 3 pairs required. That's published, and it's on our website under published papers. We have 50 cases of cervical myofascial pain published in 1998, 4.7 years average chronicity. Patients sort of served as their own control. It was 50 cases, but 88% of them had failed with 3 to 6 other practitioner types. Took 11 visits in 8 weeks because I didn't know what I was doing in 1998. Back then I treated the muscle. These days we treat what causes the muscle to be tight. Pain level went from an average of a 7 to an average of a 2. Lumbar myofascial pain, this was published by Leon Chatow in another well-known osteopath and a dear friend in JBMT. 8 years chronicity, range was 2 months to 20 years. 87% had failed with 3 to 6 other practitioner types. We figured if they were going to have a placebo effect, they would have had it with somebody else. So it took 6 visits in 6 weeks to get their pain from an average of 7 to an average of a 2. Neuropathic pain, N of 20. Average chronicity was 7 years. Every single patient of the 20 experienced pain reduction, average of a 7 down to about a 2. Second treatment, they came back in at about a 5 and left it about a 1. And so some of it held, and eventually 65% of them fully recovered in about 5 treatments. If anybody here has ever had neuropathic pain or treated a patient with neuropathic pain, you know, that's not that easy. What's interesting is that 25% of them terminated care prior to recovery. And I think it's because, well, back then I actually didn't know that I needed to deal with spinal cord and central sensitization. And if you've been in pain for 7 years and it's gone in 60 minutes, you actually don't know who you are. We have the ability to create an identity crisis that's more or less unparalleled in medicine. Ulnar transposition surgery, we talked about that before. This was published by a group in India. It's a retrospective case control study, pre and post treatment numerical pain scale in low back and neck pain. Low back pain, 213 in the Fsm group, 167 with low back pain, 46 with neck pain. The control group was 78. Fsm results considering all objective measures. P-value was 0.006. Neck pain, no significant difference. And I checked with them because I didn't have anything to do with this study. And it was published in JBMT, but I didn't even get to review it. I was too busy. And it turns out that they were using the wrong protocol for neck pain. So they're going to redo the neck pain arm of that. Delayed onset muscle soreness, post-exercise muscle soreness. Allen published a paper in 1999 that showed that microamperage current, non-specific microamperage current doesn't work. There is no preventative and there is no treatment for post-exercise muscle soreness. So this study was done by Denise Curtis in Ireland in 2010. After exercise, the frequencies that were used were the frequencies to stop bleeding, to help repair the micro tears in the connective tissue and the tendons, reduce inflammation in the blood supply, the fascia, the tendons, and then support vitality. But this is the data. At 24 hours, the treated leg, so they had one treated leg, one sham leg. Treated leg, the pain was a 1, the sham leg was a 5. By then the patient was clear about which was which. 48 hours, treated leg was 1.2, the sham was a 7, 72 hours, 0.7, and the treated leg, sham leg was a 4. P-value is 3 zeros and a 5 at all time measures. And the thing with delayed onset muscle soreness is nothing else works. No drug, no nothing. Nothing else works for delayed onset muscle soreness. So this is the one study we have that gives you an idea about what's possible post-operatively. This was a 38-year-old, 3-year chronic stroke patient. She had typical sensory motor spasticity. She had sleep apnea. And at the age of 38, adenoids and tonsils were huge. They removed those. This was about at the 20-minute mark. We ran the frequency to increase secretions in the sensory motor cortex. That's off that list. And at about 20 to 30 minutes, that's her hand was no longer spastic or cramped. She could bend her wrist. This is a physical therapist that came with me to Taiwan, and she's doing typical ranging for a stroke patient while we're running, and the current's running from the neck to the patient's feet. You can see she's a little bit floaty here. When the frequency is correct, they get kind of stoned. This is at the end. We took the current off and she was able to maintain. Now her fist, when she raised her hand, her fist still got spastic. I didn't believe that it would last, so we treated her. This day was a Wednesday. I taught the advanced course in Taiwan over the weekend, and I wanted to see her. This is Monday morning. Her range was maintained from the previous Wednesday. We treated her for another 60 minutes, and that is her arm behind her head. And those improvements were maintained until she had a subsequent stroke because nobody told her to use the CPAP. So clinically, I mean, why wouldn't you try this? It's low risk. As long as you don't drop the box in their foot, you're not going to hurt them. The frequencies either work or they don't work. If they don't work, they just have no effect. The side effects have been transient. So you double somebody's range of motion in 30 minutes, and sometimes facets or bone spurs have an opinion about that. But every student is given precautions and contraindications. Fortunately for me, medicine's pragmatic. It's like, well, does it work? And then they figure out the mechanisms later. So we use willow bark and aspirin for what, hundreds of years. And they didn't discover prostaglandin chemistry until Upjohn developed Advil in 1970, 71. So you got to ask what would happen to healing and everything you do as an osteopath if you could reduce inflammation, LOX inflammation by 62%. Lipoxygenase-mediated inflammation is involved in every degenerative disease. COX-mediated inflammation is in joints and cardiac problems mostly by 30%, reduce all of the inflammatory cytokines, and increase ATP production by 500% in 30 minutes. What would happen? So I've taken to saying that FSM is a tool that makes medicine faster, more efficient, more effective, less expensive for you and the patient, and it improves patient outcomes. We teach a 5-day core seminar in the US, the UK, and Germany. We have 2 3-day US modules, and all of these are live stream. We live stream them during COVID. There's one 5-day in-person course in the US. There's a 5-day in-person course in the UK, in Germany, and Italy. If you want to go to Tuscany in June, come join us. 2 3-day US module. There's a pain and injury module for physical medicine practitioners, and there's a neurovisceral module for people with a more comprehensive or integrative medicine type of practice. And the in-person seminars includes 6 hours of hands-on practicum, because using it is where you actually, once you feel the tissue soften, once you, in response to a particular frequency and nothing else, once you feel that, you can't ever unsee it. You can't unfeel it. The video training includes 4 hours of individual practicum training with an FSM practicum instructor, and we have them all over the world, in the US, the UK, and Germany primarily. It's a little bit like taking a drink of water out of a fire hose. You're immediately competent, overwhelmed, but safe. And what you don't learn in the seminar, the frequencies will teach you afterwards. I finally figured out after 20 years of doing this that the job of the seminar is to teach you how to think when you have frequencies as a tool. So when you're treating peripheral pain or SIBO, let's say peripheral pain, you don't even think about how would I reduce spinal cord sensitization and central sensitization, because you don't have a way to do that. With FSM, you set one frequency, one device, a little device, to treat spinal cord sensitization, because we know 40 and 10 does that. We have all that data. Central sensitization, and then you treat the peripheral tissue. When you're treating SIBO or gastroparesis or vocal cord dysphonia or any autoimmune disease, never occurs to you to treat the vagus nerve, because you don't have a way to do that. If you're treating an autoimmune disease or SIBO or gastroparesis, the only way to fix it is to turn the vagus nerve back on. And that's a whole nother conversation. So you're overwhelmed but safe. The original learning curve is about 3 months. But in the last year, and I've been doing this 25 years and hundreds of thousands of patient experiences, and I've used frequencies this year that I've never used before in combination because of what a specific patient needed. So we have advanced courses, and that's where Dr. Clearfield lectured, because we have frequency protocols for treating brain injuries. And the frequencies aren't enough. So Dr. Clearfield's lecture was, what do you do when frequencies aren't enough? Well, you got to look at the endocrine effects. I found his slides. Somebody sent them to me. I contacted him. He came and did a lecture. What do you do when frequencies aren't enough? Well, the other lecturer that morning, that afternoon, was Dr. John Reski. He's an optometrist, an FCOVD optometrist, who talks about the uses of prism glasses and the visual system in brain injury patients. So my goal is to bring healing to every patient that wants it by training practitioners who can treat them. We have webinars, we have a podcast, we do workshops all the time. The equipment is inexpensive by any medical equipment standards. It's US made, ours is. It's FDA 510K approved, ISO certified, and we finally got a CE mark. So in short, FSM is a new tool you probably didn't know you needed that does something there's no reason you should think it was possible. I wrote a book in 2000 that was published in 2017, Penguin Random House. And it's Jim Oshman wrote Energy Medicine, the Scientific Basis. Some of you might know of him. He's a biophysicist, and he just loved it. He said he can't put it down. It's a page turner, and it's a story of how FSM was developed and how it is that it's changing medicine by changing what's possible. It's not possible to get rid of nerve pain in 60 minutes, not when it's 7 years chronic. And nerve pain is the easiest thing we treat. So I have to warn you, frequency specific microcurrent, it's gonna change your life, your health, your practice, and your outcomes. Each of you has your own specialty, but as far as I'm concerned, my job is to make your job easier. And FSM is a tool that helps you do that. But it changes everything forever. And as a group, this is our mission statement, if you will. We are changing medicine, but you can only do that one patient at a time. We are all aware that this is a profession that took 50 years to learn to wash its hands. And then we change lives. I just train one practitioner at a time. I traveled to Hartford, Connecticut to teach a seminar to 6 practitioners. 4 of them didn't show up. One of them was a physiatrist from Cleveland Clinic in pediatric rehab. And that practitioner recruited just by practicing, just by treating pediatric patients. He recruited every PT at Cleveland Clinic Pediatric Rehab, some of the adult PTs, and all of the MDs and DOs at Cleveland Clinic Pediatric Rehab. And the thing that makes my life the most fun is changing even one patient's life. It changed the world. I think that's what we're all in medicine for. I think that's it. We're back to the beginning. How do I get out of this? So that's aha. All right, now what do I do?
Thank you so much, Carol. That was terrific. And that was just a smattering of what our speaker brings to the table. It was truly astounding. I was there for 4 days, and she had three separate lectures going on, breakout rooms. She was teaching for 2 or 3 straight weeks, beginners, advanced people. She's going, where are you going to Italy? You're going to Italy, you told us, this summer, and the UK. And it's quite a fascinating subject.
And it gets addictive because it's the one meeting where people talk to people that speak their own language. So you can talk to somebody at a table. So we had special interest tables at the second day at lunch. There was one group that just treated PTSD, and there's one special interest group for nerve pain, traumatic brain injuries. And you can say to somebody, it was really pretty straightforward. She was a 40 and 10 and a 40 and 89. And then you just threw in 40 and 396.
Oh,
and
that's right. I forgot. So those of you who remember a story written by Ray Bradbury called Fahrenheit 451, it was one of the first science fiction movie that was made into a movie. It was very cheesy special effects. but it was a society where you were not allowed to speak words. You could only utter numbers. And
Wow.
so, yeah, there would be one person would say the other 62 and the other one would say 147, and they would laugh. It was some sort of joke or something. So yeah, so there was that too.
Yeah, well, and the practitioners are so enthusiastic because there is something just so exciting. I mean, you could tell in your audience, was anybody playing with their phone? They were hanging on every word, because as a group, we tend to just be completely obsessed with getting patients better. And they know that FSM is an essential component of that, but it's not enough by itself. You have to create a stable state. And and the other thing is, the other analog to it is, people have called it electronic homeopathy, but I don't have to wait 3 weeks to see if it works. It's 60 seconds and it either works or it doesn't. And you can combine it with other frequencies and do multiple things at a time. So it's pretty fun. I'm really glad you had a good time, because we really enjoyed having you.
Well, the funnest thing for me was when you said, when it came my turn to speak, and you said, well, we do what we do, but it's not quite enough. So here's the missing link. And then you introduced me. So
Yep.
I quite enjoyed that. So I see a hand up for Dr. Gerber. I'm not sure why, but
I'll talk to him.
or is this was just an accident? I'm not. So so if you're there, Dr. Gerber, we're all ears. If not, that's okay. Anybody have any questions? So if you could, in the chat, Carol, and I'll pass your information on also, if you want to just put down your contact information.
Oh, thank you, Dr.
You
Burgess.
Wonderful, wonderful information. Thank
You're welcome. Read the resonance effect for the rest of the story. It's how this thing developed and came to be. And then, like, chapter 10 was all written by patients. If I was the only one that could do it, or I was the only one that could help people, it wouldn't matter. But chapter 10 was written by patients. So the resonance effect is your friend.
Okay. Could you tell us one story though? Because so you don't know this, but so I'm from Philadelphia, and I might have told you this. So I'm from Philadelphia, and in 2004, the Philadelphia, we're perpetual losers. And in 2004, the Philadelphia Eagles are going to the Super Bowl, and their star receiver is Terrell Owens. And the last game of the season, he breaks his leg and he tears all sorts of ligaments, and he's supposed to be out for a whole year. And it was kind of like, a deflating moment. Tell us what happened. I read about it in your book.
Yeah. Well, I had treated Terrell the year before when he was with San Francisco, and his trainer called me on Monday morning. His personal trainer called me Monday morning and said, Terrell's been hurt. He had an open spiral fracture of the fibula. He tore the interosseous membrane. He avulsed the deltoid ligament from the lateral ankle. And he said, Terrell's been hurt and he wants to play in the Super Bowl in 6 weeks. Mike Hatrack is his chiropractor in Atlanta, and Hatrack says he's not going to touch him. You've got to do it. So I did, and he said, can it be done in 6 weeks? And I did the math, and I said, in a perfect world, yes, but I have to be there when he gets out of surgery. So I canceled patients, took the red eye, was there at the hospital when he got out of surgery. I put the adhesive pads on him. We loaded him into a stretch limo, laid him down on the seat. I treated him. All I had was the big analog blue box that you saw. And he had a sports care unit. So he'd been treating himself for the fracture since Sunday night, right after it happened. And I treated him in the car on the way home, and I literally treated him for 24 hours straight. And so that was Monday morning. Tuesday morning, the trainer from the Eagles, Rick Burkholder, came in and said, okay, let's see this. And you expect after that surgery that the foot is going to be about the size of a, I don't know, soccer ball, and black and blue. We took off the boot, cut off the bandage, and there was 0 bruising and 0 swelling. Both ankles looked identical except for the pins and screws. We treated him basically 6 hours a day, 6 days a week for 5 weeks, 4 weeks. I took a week off. The team from Atlanta came up and treated him. And there are frequencies to dissolve scar tissue that are so effective that I wouldn't use them. You don't use them until 6 weeks. So we were 5.5 weeks when I got to Jacksonville. He got to Jacksonville on Tuesday. He couldn't run. And I said, it's just scar tissue. So we spent, Brian Glotzbach and I spent 5 hours taking apart the scar tissue in his lower leg, the nerves, the muscles, the periosteum, all of it, clear down to the bone. On Wednesday, we worked on him another 2 hours on Thursday. Mike Hatrack came and adjusted that $6 million ankle. And Friday, he ran like he'd never been hurt. When he got to Jacksonville on Tuesday, he couldn't run. And Friday, he ran like he'd never been hurt. Sunday, he ran for 157 yards. They lost, or people might have heard of me. But that was mostly because McNabb didn't like getting sacked, and his offensive line wasn't having a good day. So yeah, that was probably the coolest thing I've ever done. And the thing about Terrell and Buddy Prim, his trainer, is that it's that stable state. He already had the stable state. It was like working on a Ferrari. Buddy's players are allowed to have grass-fed beef only, and they may have beef 1 day a week. They can have salmon, they can have organic chicken, no rice, no potatoes. They can have sweet potatoes, no sweets, no milk. And so his players already have a stable state. He makes college athletes take a 2-hour nap in the afternoon. So that's the stable state. It was pretty fun. But thank you for bringing it up. It's my favorite story.
Yeah, well, when I read that, I had to send it to my brother, who's a big fan and has been a season ticket holder for 45 years, and that's a lot of suffering. So
yeah, it was.
So David, let me ask you this: you heard what Carol had to say. How does this relate to what you do?
This is excuse my voice. I lost my voice. Can you hear me okay?
Yeah.
Yeah, we're good.
Carol, Dr. Carol, thank you. We have a resonance-based PEMF technology. It came from Germany.
Sure.
And so many similar results, but not as dramatic. It seems like your ability to concentrate that resonance is far greater, and it's a home therapy technology. They take it home, they treat themselves. Have you looked into it all comparatively? No, not all PMF is the same, but this is a resonance-based PMF. So just wondering if you had any experience with that. This is QRS from Germany. Yeah.
It's the single channel. Most of the pulse TMF is single channel, and current moving electrons create a magnetic field. Magnetic fields move electrons. So pulse TMF moves electrons, which increases ATP production, which by its nature reduces inflammation and produces the effects. You give any cell 5 times the amount of energy that it had, and it's going to do something useful with it.
Mm-hmm.
So the combination of the 2 frequencies together have been surprising. So there's a pulse TMF device that the Germans are coming out with that has my technology in it. So it has 2 channels in a pulse TMF unit. We've got 25 protocols that I deemed safe for patients to use at home. And that's the only comparison I have is the theory, and the people that have moved from pulsed EMF to FSM or use them together. They're not mutually exclusive. So there's nothing wrong with having a biomat or a beamer or a whatever, and then using FSM therapeutically at the same time. Nario says, how much is a unit? The what we call a custom care is a small programmable unit. It'll hold about 45 protocols, and there's computer software, and it can be reprogrammed indefinitely with whatever sequences you need. So I run it on myself with a magnetic converter. So it converts frequency-specific electrical pulses to frequency-specific magnetic pulses. And I think, do you know how much custom care is? 2,400 with the software. I think the custom care is 2,400 with the software. The precision care is the one where you learn, you do specifically what the patient needs. That's where you figure stuff out. And that one I think is about 6,500. It's a 2-channel manual unit. So you're treating somebody who can't straighten their leg or who has pain after a knee replacement, let's say, and there's no reason for it, blah, blah, blah. And you run the frequency for metallic toxin and muscle contraction, metallic toxin in the bone marrow. Muscle contraction turns to normal immediately, pain goes away. And it turns out that the patient is very likely allergic to chromium or stainless, and they put in a stainless implant. So we've done it. So there's no way you would know that just by running joint pain on a custom care. That's what a precision care is for. So there's actually 2 units. I do the research treatment research with the precision care, and then I'll use a custom care for the standard stuff, like improving vagal tone. That's a slam dunk. That's just standard. So we run that from the patient's neck to the patient's abdomen for visceral conditions, anything autoimmune, SIBO, gastroparesis, anything, even inflammatory conditions. The vagus is in charge of turning off the immune system and controlling T cells and macrophages. So it's the specificity that's different. Pulsed EMF devices operate at different frequencies. So when you say it's resonance based, I'm assuming you have different frequencies that you can choose.
Yeah, that's right.
But it's still single channel, right? It's one frequency.
I'm going to do more investigation once I study everything, because as you say, everything is the patient. How do we transform lives? So I'm completely resonant with you on it. So
There you go.
I'd like to see this synergy between the two.
Yeah, there's no reason not to use both. Same thing with homeopathy. Any nutritional therapy that you're doing, if you have somebody that has PTSD, for example, the data we have in PTSD is insane. We don't have anything published, which is frustrating because the military won't allow any of the clinical things that have been done on military patients. But PTSD scores go down by 50% in 4 sessions when the PTSD is 6 to 7 years chronic. And in PTSD, no improvement is expected after 2 years. So to get a 50% improvement in 4 sessions in a month is not possible. And the full protocol calls for 8 sessions in 7 weeks. So twice the first week and then once a week after that. And then you can decrease the medication and use supplements to support neurochemistry and general health. It's a really good combination. Same thing with traumatic brain injuries. We use supplements, but now people know what testing to do. Dr. I don't want to mispronounce it, Moljo, depression and anxiety. If you look at the causes, so my bachelor's and my master's are in psychology, and I'm a little bit of a neuro geek. So when you look at the causes of depression, anxiety, cognitive dysfunction, they're all inflammation. So we have protocols for the brain, the medulla, the midbrain, but the best way, yes, neuro geeks unite. The best way to turn off depression and anxiety is to turn on the vagus nerve. So the vagus, 80% of vagal fibers are afferent. And the vagus has as its job to know.
Turn the dryer on.
Say again? Okay, so the vagus notifies the brain of infection, stress, and trauma. And the brain turns the vagus down. That increases inflammation. So inflammation in the brain is part of what causes anxiety and depression. There are frequencies for the midbrain, which in our world, we only have one frequency that includes the amygdala, the hippocampus, and the thalamus. So it's good for phantom limb pain. It's good for thalamic pain from strokes. And it's good for anxiety and depression because it includes the amygdala and the hippocampus. So the combination of being able to reduce inflammation directly and turning on the vagus to reduce inflammation in general makes it pretty useful. We had one practitioner who came to a seminar. He was an interventional cardiologist, and when he was his turn to get worked on during the practicum, he said, "I've had anxiety for 5 years." I don't know if any of you are interventional cardiologists, but those guys work without a net. Anxiety? So as I was treating his abdomen, he also had digestive difficulties. I got to thinking, what would cause anxiety? Well, it had to be the midbrain. So I put the frequency for the midbrain on channel B, and I ran the frequency for inflammation on channel A. Didn't do anything. Okay, what else? Toxicity. So there's 3 frequencies for toxicity. And I ran the first one in combination with the midbrain, and the patient went from talking and wide awake to like
All my digital
asleep,
creators out there,
like he gave
here's
him
what you're
half a cc of Versed, just gone. And he slept for 20 minutes, and I let that run. When he woke up, I switched to the next one. He fell asleep for another 20 minutes. And at the end of all 3 frequencies, at 60 minutes, his anxiety was gone and stayed gone for 3 months. So there's something probably in the hospital that he started working at 5 years before that is toxic for him and creates problems. So they have their own unit at home, and he just treats himself. So yeah.
So how long is a session?
How long is what?
How long would a session be? You said he treats himself. Is it a half hour? Is it an hour? Is it 5 minutes?
It depends. It really does. There are some things where if we had one practitioner from France who had French managed care, they have 30-minute sessions, and he presented a case report at the symposium in 2017, I think, or 17. And he had a patient who was scheduled for thoracic outlet surgery where they were going to remove her first rib. And he treated her in 30-minute sessions for twice a week for 6 or 8 weeks. At the end of that, her thoracic outlet was gone. Surgery was avoided. he had 30-minute sessions. Back when I first started doing FSM, I had to see 3 patients an hour to support my overhead. So I had 3 rooms. I kept 3 rooms full all day long with 1 assistant. And the patients were booked every 20 minutes. But the patients were in the room for about an hour. So it just depends on how much time you have. In general, the patients take space. They don't take time. And almost all MDs and DOs can't afford to spend 60 minutes with a patient. But most of you have multiple rooms, and most of you have clinical assistants, medical assistants, massage therapists, somebody. So I start with the patient, tell my assistant what to do, get started, turn them over to the assistant, go into the next room, see the next new patient or see the next patient, do the history, do the physical assessment, get them started on treatment. Then I go back, swap with my assistant, send her into the next room, and you can keep 2 rooms full all day long. The biggest challenge people have is your chronic patients get better. Like, they get better.
I know what a concept, right?
Yeah. So your frequent flyers.
That's supposed to happen. That's not supposed to happen.
Exactly. You're supposed to see them like once a week or once a month forever. And they get better. And the challenge then is learning how to deal with new patients. So every chronic pain patient you see knows 6 people just like them. And every one of them, when you get them better, and you're the guy that sends them home repaired, they tell their 6 friends. So every receptionist that I had to learn 1 new patient a day, because otherwise I ran out of follow-up visits. So 1 new patient a day, and every patient you plan on twice a week for 4 to 6 weeks. Some of it's for rehab. Some of it is that's just how long it takes to get not only the original complaint repaired, but the compensations. So you fix somebody's shoulder and you increase the range. Well, what happens to the lats? The lats connect to the low back. So the 2nd and 3rd treatment, you're still treating the shoulder. By the 4th treatment, you're treating the low back because their gait completely changed because the lats attach to the low back. So if you plan on twice a week for 4 to 6 weeks, they're better. And they send their friends. So it's pretty fun. Most of the time it doubles a practice in about 6 to 12 months. So, and even if it doesn't, it's just so much fun. It's a lot more fun to go to work than it is to stay home.
Well, there's that too.
Yeah.
Anybody else have any other questions?
Yes, please. Hi.
Yes, finally. Yes, Dr.
Hi.
Gill.
I tried to figure out this whole computer thing. Hi. Enjoyed the lecture enormously. Been at this like you a long time. And is your contact frequencyspecific.com/core?
Frequencyspecific.com is the website. I think the classes are frequencyspecific.com/core. Yeah, that's how to sign up for courses. And most people take them on video these days. The 5-day comprehensive is intellectual overload. It is a lot because fully 50% of the course is diagnosis, and that's not what you call it. It's how you think about a condition when you have to treat the cause in order to fix it. So I was married to David Simons, and David wanted trigger points to be a muscle disease so the medical profession would accept it. As the years have gone on, it turns out that we have to treat what is causing the muscles to be tight. And that's a whole new concept. Facets, discs, ligaments, nerves. So that's the 5-day course. So it's better to take it on video and then come to a 2-day practicum. So we're in Denver, Atlanta, Philadelphia. Oh, and
Type
which
it in.
one?
We'll type it into the chat.
Type it into the chat.
You can give mine if you want.
Where are you? Tell me, Kevin.
Click down here.
Oh, type a message. There we go.
And then just
So contact a frequency specific.
Dr. Clearfield,
Yes, Dr. Gerber.
hi. I bet you that this frequency work is terrific for dental issues.
I'm sure it is.
Well, yeah. So we have a dentist. Did that go on, Kevin? I don't see it. There we go. It was to Dr. Burgess. Anyway, so we have a dentist who actually patented the use of frequency specific microcurrent in dentistry. So in medicine, I couldn't patent the frequency and didn't want to, because once you patent something, the only point is to be able to sell it, and then you have to defend it, and it's like more trouble than it's worth. But Mary Ellen Chalmers patented the use of FSM in dentistry. So in 2007, I had open heart surgery, single vessel, single lesion with no risk factors. Every other vessel was clear. And she said, this isn't right. So she kept looking, and we finally had a 3D cone beam, and I had 9 root canals. And the whole back half of my jaw, upper and lower jaw, was necrotic. So I've had nine jaw surgeries, 6 to remove infected bone and teeth. And that sounds pretty horrible, but because I used FSM immediately after the surgery, I didn't have any pain, didn't have any swelling, no bruising, like zero, nothing. TMJ is fairly straightforward these days. We finally figured it out. You just fix what causes the TMJ. The challenge with inflammatory periodontitis is it's usually infected, and then you need a 3D cone beam to do that. The other thing that she's done is after orthodontia, to use it for the ligamentous strain and new injuries. So she has a bunch of protocols for that. So yeah, it has turned out to be good for dentistry. Thank you for knowing that.
Great,
Cool.
great. Could you give us the name of one machine that you like?
Oh, Precision Care. If you go to Precision Distributing, Kevin will type it in. So Kevin is the reason why the tech around here works. Okay, he's gonna do that.
Thank you. Thank
Yeah.
you. Thank you.
Yeah, precisiondistributing.com. We don't publish the prices because if you want to sell a custom care to a patient, your cost on that custom care is around $2,000. And we've had people sell them for any place from $2,200 to $3,500. We don't want the patients to know what you paid for them. So in order to be allowed to buy a machine, you have to have taken the course. So Precision Distributing, Precision Distributing will sell bundles. So you can take the course and buy a custom care at the same time for sort of a bulk price at a reduced rate. Selling a device to somebody who has not taken the course is like giving a 3-year-old an Uzi. Bad idea. There were a few people who took my course and then published the list of frequencies on the internet on their websites without any precautions. And I just went ballistic and sent emails to all 3 of them. I made up a list of things you have to be careful with and sent it to them. We published that, be careful with these lists. So for example, the frequency to increase secretions actually works. So I have data from an N of 1, me as the lab rat. I ran the I was postmenopausal on supplemental estrogen. I ran the frequency to increase secretions in the ovary. And my salivary estrogen went from 1.4 to 37.1 in 30 minutes. Now, I was nauseous, fatigued, had a headache, felt pretty awful. And thankfully, my liver was able to detoxify all that excess estrogen. I got off that frequency, went to something else. And
You need a progesterone frequency.
yeah, no, I wish, because we don't have a frequency for the corpus luteum, right?
Right.
And there are frequencies for the anterior pituitary. I discourage people from messing with the posterior pituitary just because what if it works? Do you really want to mess with ADH? I don't think so. I was treating somebody with a hypoxic brain injury. He was basically locked in. Eyes were open, but unfocused, non-responsive, on a trach. He had a hypoxic injury after a Fsm injection. He fell asleep and just stopped breathing between the procedure room and the recovery area for 4 minutes. And that took care of that. So I was running through all of the parts of the brain, doing the standard and then increased secretions in the cortex. And then the next frequency on the list was the midbrain. And I ran as the 4th or 5th frequency combined with the midbrain. I ran the frequency to increase secretions in the midbrain, which includes the amygdala, the hippocampus, and the thalamus. And this man, effectively in a coma, started to cry. Tears running down his face, chin quivering. I reversed it because I knew what I'd done. But that means the frequencies really do what they're alleged to do, whether that's what you want them to do or not, right? So that's why the course is so detailed. If the frequencies were just a blow off, it wouldn't matter. But the fact that they actually do what they are described as doing means that you use them thoughtfully. So anyway, so that I can't even remember what, the progesterone. Yeah. So that's, I can't even remember what you asked me that got me going down.
You
that
said
route.
you stimulated the ovaries to make estrogen.
Oh,
You
right,
got a headache. You were nauseous.
right.
Probably a little agitated, irritable.
No, that's really just exhausted, just
Yeah.
completely exhausted.
So you
And-
needed the progesterone to balance it.
Well, basically, I needed to stop running that frequency and let my liver detoxify all that estrogen. But
Well,
the
there's that too, but
Yeah.
I'm just giving you the alternative. So.
Yeah, right. So the frequencies do more or less exactly what they're alleged to do. And over the years, over the last 25 years, placebo effect is been kind of eliminated as operational. It's always helpful if you can use it. Could you use this for treating reflexes? When somebody has a cervical or thoracic disc that creates inflammation that slows descending inhibition, you get hyperactive patellar reflexes. When we treat the spinal cord for either inflammation or to increase descending inhibition, we can get rid of hyperactive patellar reflexes. But I'm not sure if that's what you are talking about, Dr. Bibona. But yeah, if you can get the nerve and the spinal cord functioning properly, the reflexes go back to normal. One of the case reports in the book, The Resonance Effect, is a patient that came in with fibromyalgia and RSD or CRPS. And the CRPS, she came in on Monday, the CRPS was gone by Wednesday, and the fibromyalgia was gone by Friday. The following week, we kept her in rehab, kept doing FSM. She had two facets in her lumbar spine that were still jacked up. And I had a really good PM&R injection specialist, and he did facet blocks. And this was in 2000, where I actually injected the facets. He did facet blocks on her, and she left 2 weeks after she came, completely pain-free and recovered from two
Yeah.
full conditions. That's the high spot of my life. Better than Terrell Owens, actually, although he was really fun.
So how does it work with you? If you said the units home with the patients, if you said the practitioners play around with it and get themselves in trouble, what happens with the patients?
Well, you use the units in the office. So I'll treat with the manual unit. I'll use the custom care in the office when you're sure that the patient is stable and what they have needs retreating. So Ehlers-Danlos has become really straightforward. It's just not that hard. I know that sounds weird, but there's one frequency that appears to change the integrity of the connective tissue. So you run that frequency neck to feet. Their body pain is spinal cord, because the disc annulus is made of connective tissue, and their discs leak, and that inflames the spinal cord. So you treat as you would for cervical trauma fibro. So 40 and 10, neck to feet. Treat the connective tissue, neck to feet. Ehlers-Danlos patients have anxiety, depression, gastroparesis, SIBO, all of the digestive difficulties, because every time they stand up, their vagus nerve gets a traction injury because the basement membrane in their gut is too loose. So you treat the vagus. So that's 1, 2, 3, 4 machines. And you treat them, let's say on Monday, and then you have them come back on Thursday, because it usually lasts about a week. So before they go back to baseline, you treat them a second time. And then you tell them, I want to see you back in 5 days. This isn't going to last. And they come back in 5 days, you treat them again, it works again. So by the third session, they expect it to work. And then you let them go a week and find out that it comes back. Then they have one unit that they buy and they treat themselves. I don't have time to see somebody in my office every single week. I don't have enough spaces. So Ehlers-Danlos patient, you send them home with a home unit once you know what they have. I had a patient she had radiation treatment for it's not a glioblastoma. What's the pediatric spinal cord tumor that kids get? Anybody remember the name? Some sort of blastoma. Anyway, they took it out surgically when she was 18 months old. It came back when she was 3. They radiated her spinal cord. I got her when she was 29. She was ataxic, spastic, depressed, all of those things, in constant pain. And I had to run the frequency to reduce inflammation in the spinal cord. We treated her to take the radiation damage out. But in order to change the spasticity, we had to use the frequencies to increase descending inhibition of spasticity in the spinal cord. And so she went home with 2 units when she was 29. She's now 36. She uses the units every single night. She's finished a bachelor's degree. She's in a relationship. She's mentally healthy, not depressed, off of her meds, and she walks. So that's what the custom cares are for. You send them home with patients after you know what the patient needs and what's going to work.
So to set up a little clinic, how many of these machines do you recommend?
Oh, depends on a lot of things. Neuroblastoma, thank you. Neuroblastoma drives me crazy. I knew it wasn't real. Thank you. I appreciate that. When I set up my clinic, you can do it with 1 precision care and 2 custom cares in a room, as long as you can reprogram the custom cares for what you need them to do that day. because of the kind of patients that I get. My whole practice for 25 years has been the 5% of patients that nobody else can fix. So probably not unlike the rest of you. So in my treatment room, I've got two or three precision cares and 2 custom cares, but I usually use 2 to 3 to 5 machines on a patient at one time. So I can get basically a month and a half's worth of work done in 60 minutes. So it just makes it easier. Ben Catholi, who was at Cleveland Clinic PM&R, he's moved on to Shirley Ryan, but he still holds the record, and I still don't know how he did it. He had 7 machines connected to a 2-year-old. And it worked. So there we go. So it's the baseline would be 1 precision care and a custom care. Once you get busy, the machines pay for themselves because they're approved in the category of TENS devices. So is FSM approved? No, the FDA doesn't have any opinion about the effective frequencies. It just doesn't. The devices are approved in the category of TENS devices. So they're reimbursable as if they're TENS. They don't pay a whole lot, but it pretty much replaces your advertising budget. And even at minimal reimbursement rates, if you're in insurance-based practice, if you're in minimal reimbursement rates, they pay for themselves in about 3 months. So it works. And you have to get a rolling cart. And I personally use wet wraps. So I have a towel warmer in each room. And you go to Costco and you buy white washcloths and white hand towels, and the devices come with alligator clips, and you need fuzzy blankets to keep people warm. So it's a setup, but we talk about all that in the seminar, kind of the practical aspects.
So the question is, are the FSM training courses the same and the equipment different according to the bundles?
The training courses are the same. The equipment, the bundles will sell. I think there's one bundle that's a precision care and a custom care with the training. And then there's the training and a custom care. And then you can, once you've taken the training, you can buy anything you want, and you can train your assistants. So if you take the course on video, I don't have any problem with, as a matter of fact, I encourage you to show the video to your medical assistant or your clinical assistant, because they're the ones that are going to be doing a lot of the hands-on work, and they need to be trained. So yeah, that's the way I'd recommend using it. The other thing is, I don't know what I'm 75, and I have a history of dental infection, mold, exposure, all of that stuff. And I use my custom care every single night, treat insulin resistance. And anybody that has been reading Bredesen knows that one of the ways you prevent dementia is by getting insulin resistance down. So I treat insulin and leptin resistance every night. And then when I wake up at 2 or 3 o'clock in the morning, I treat the vagus nerve, because these days, rather than turn down specific inflammation, I let the vagus nerve do it. So the vagus nerve has as its job to suppress the immune system, especially T cells and macrophages. So sometimes turning down inflammation is not the best thing to do.
Mhm.
Let the vagus nerve decide how much you want to turn it down. It's pretty fun.
Okay, yeah, Carol, you are super. So I hope everybody here enjoyed this. You know, I can't tell you what a great time I had in Phoenix, and I hope you invite me back sometime.
Oh, we will
Well-
have you back. I mean, you found everybody has a tribe, right?
Right.
Yeah, and you and what's his name? Bill, fourth, Pollock? William Pollock. Jerry Pollock. Yeah, Jerry Pollock, Fourth Phase of Water. He came in and lectured about the cells, gels, and the engines of life. That's the first book. And then the Fourth Phase of Water. Cells, gels, and the engines of life is transformational, just makes you completely think about biology in a different way. He walked in, lectured to our group, and had exactly the same reaction or response that you did. It's like, you've never heard of these people, but you're part of the tribe.
Yeah, it was like I said, the first thing I said was I have no idea what I tried to read about it and I just didn't resonate. But by the time I left, I have a pretty good idea. And I promised you I was going to take the class. So tomorrow I'm going to Miami to the Age Management Medical Group. And then after that, then I'm free. So
Yay.
next
Welcome to the
next
tribe.
week, you'll be getting us. So
There you go.
okay. So anybody else have any comments or questions? I think we should let Carol go. It's getting late on the East Coast. It's almost 7 o'clock.
Not for you guys.
Anybody else? Next week, we have Egan Walker, who is a local judge. He's a district judge. And I thought it might be interesting since, you know, a lot of us do all sorts of alternative medicine things that are outside of the quote unquote standard of care. You know, we're going to bring in Judge Walker, and he's going to tell us all the things that we're going to be, you know, have to be afraid of. So thank you, Kevin, by the way.
Thank you, Kevin. Bye. So Kevin is why I don't have IT problems. All he has to do is stand next to the computer and it behaves.
Well, we certainly could have used it in Las Vegas last week because we had nothing but IT problems. So,
Yeah.
And so, oh, by the way, those of you that were there, you know, we had, you know, the IT went out 5 minutes before our show started, and our first speaker was in Pakistan, and it took them over almost 2 hours to get it going again. So I jumped in and gave actually the lecture that I'm giving this week in Florida. I gave it just because, you know, the show has to go on, and not everybody appreciated it. I got some bad reviews. I thought, you know, with no preparation and no plan to jumping in there, I thought he did an okay job. So any of you that were there, let me know, because I was a little stunned at 5s and 6s out of 10 for, you know, a spur of the moment.
Just as a suggestion for the next time, when we have virtual presenters, they pre-record everything. You can't trust the internet at all. So we
don't have the hour to go on to deal with what went on with those people there. But
no one says,
rest assured, we will never go back to that place again. It was the Flamingo Hotel. I know the first question to ask when we go there. So we ran into a union problem, and if you're a union person, I apologize, but no one told me anything about it until 4 days before the show, that we had to have, and they wanted $35,000 to run the internet for 3 days.
Yeah, right. Tried that in Las Vegas. I don't think so. And everybody says you did a great job.
Well, we survived. We'll just leave it at that. I don't want to do it. I don't want to do it again next week. I'll tell you that much. So I'm still in recovery mode. So okay. So next week, like I said, Judge Walker will be here. Get your legal questions together. And the week after that, I think Dr. Halassa is going to give us part 3 of his integrative oncology. And then the last week of April, Dr. Parvin we're going to be giving our certificate series. So that's what we have coming up. Thank you all again. Please bring one friend. You bring one friend, we double our house. Carol, it was great. I hope you'll come back sometime. And,
thank you for having me. I had a good time. It's always nice.
We had a great time. We always record these. We put them on our website if it's okay with the speaker. So if that's okay with you, And our website, those of you who don't know, it's aosrd.org/webinars. Okay, so all of the web, almost 95% of the, we've been doing this for almost more than a year and a half now. Every web, almost every one is there. Every once in a while, I either forget to record it, or the speaker doesn't want it recorded, or doesn't want it posted. So they're all there. There's probably 60 or 70 lectures there. Some of them, most of them have the transcript with them. So a lot of them have the slideshow also. And we're still waiting for it. It'll take another week or two, I'm guessing, for the videos for the conference. We'll have that up there on the website also. It will be password protected for 10 months because it's kind of not fair that the people that paid to go see it, they did get CME credit. By the way, if you're a DO, and you sent me your information, you should have gotten your credit already. If you're an MD, there was a little snafu with that, and I need some more information. You'll be hearing from me in a week or so, something about it. They tell me afterwards I had to collect the month and year of birth or something like that. I don't know.
Whatever.
So yeah, they don't tell me this ahead of time, so we could do it all at once. Because we had AMA credits also this year for the first time. So that's that. Everybody that was at the conference, thank you, Dr. Cruz, Dr. Burgess, and David, Dr. Patel, and Marie, of course. Don't leave Marie out up there in the upper right. She's with us. Was with us also. One thing, if someone can direct me on how to get, I have Dr. McCullough's entire talk, almost 2 hours, on my phone, and I can't seem to download it anywhere. So if somebody knows how to do that, I don't want to lose it. You can send me a message on how that's done. I tried Dropbox, I tried with OneDrive, and nothing doesn't seem to work. So but it's still there. Okay, Carol, thank you so much. You'll be hearing from me in about 2 weeks. And everybody else, we'll see you again next week, same time, same station. If you're going to Florida to AMMG, I'm speaking Sunday morning at 9 o'clock. So don't miss it, because it's always the best lecture of the whole weekend. So, and I say that modestly, by the way. But you don't have to come, actually, because if you were in Las Vegas, you heard it. That was the lecture that I jumped in and gave. So Dr. Burgess, anything else? And we're all ready to go. Oh, one last thing. Again, just to reiterate, we scored 99 out of 100 on our re-credentialing, and we've been re-credentialed for 5 years, which is the highest re-credentialing the AOA gives. So we're good for another 5 years. So
Congratulations.
okay. So great. And then Carol, again, we'll talk about getting accredited for your group too. Okay.
Wait. Thanks so much.
Okay.
Bye.
Thank you all so much. And I'm going to say good night. Thank you, Dr. Parvin. Thank you, everybody. Dr. Gerber, Dr. Ching, whoever, Mr. iPhone, Dr. Patel, Dr. Renza, and Dr. Mohio. We had some new people on. So I'm going to say good night, and we will be back again next week. Take care, everybody.
Bye.